Let me warmly welcome all of you to the second day of the annual academic program of the Sri Lanka College of Endocrinologists 2025. So I hope today will be another day full of knowledge for all of you to explore and get more knowledge on these fields. So without taking much of the time, let's start our plenary for the day, which is on malnutrition and diabetes, type 5, a comprehensive review. Let me introduce our speaker for the day, Prof. Nihal Thomas. He is a senior professor at Christian Medical College, Vellore, the Vice Principal Research and Associate Director and Deputy Medical Superintendent, Head of the Unit 1 and Head of Department, Endocrinology at CMC, Vellore, India. Over to you, Prof. Nihal Thomas.
Good morning, and wonderful to be here in Colombo once again. So I'll be talking about this entity, which is probably a bit of a mystery to many, type 5 diabetes, and what was or has been called malnutrition modulated diabetes. So in April this year, at the International Diabetes Federation, Dr. Peter Schwartz proclaimed this particular condition as type 5 diabetes, another name for malnutrition modulated diabetes, because it was a neglected and under-recognized condition requiring more research. And I shall come with a basic background to this essential condition. I'll be talking to you a bit about the introduction, a bit about the epidemiology of this condition. I shall present a case and pathophysiology and the pathobiology of this condition, which indeed there is quite a lot, and finally constructing and defining the disease and what you need to rule out before you consider this condition. So I'm just going to allude to a bit of epidemiology in terms of our own birth cohort, the Vellore birth cohort. And if you look at that, at the age of 44, that was about 8 years or 10 years back, 10% of them had a BMI of less than 18.5. 10% of those who had diabetes had a BMI of less than 18.5%. We always presume that what we see as diabetes is type 2 diabetes. But the question here is it type 2 diabetes? What was the proportion which required insulin? What was the proportion which needed oral anti-diabetic agents? And this is the question you should always ask yourselves when you see a person who's lean, not necessarily with a cutoff of only 18.5, but even with a higher cutoff of, say, even 20 or 21, less than that BMI, what are you dealing with? This is from other parts of the country in India, Tripura in the northeast and Arunachal Pradesh. Once again, if you look at this, 23% of those who had diabetes had a BMI less than 18.5. 20% with a BMI less than 18.5 kg per meter squared. And so, very often, wherever we are, it's a dustbin diagnosis when we treat patients with oral anti-diabetic agents and say they respond, it's type 2 diabetes. But are we really dealing with type 2 diabetes in this situation? More recently, my colleague looked at the data from Meghalaya, once again a northeast state. 10% of this population had a BMI less than 19 kilogram per meter squared. And what Felix also found was that in the range of 19 to 23, 25% of them had a BMI, so 25% actually. So around 35% have a BMI less than 23 kg per meter squared, which is your South Asian cutoff for insulin resistance. This is from our periphery, and that is Nitin, who has worked with the community health department. 5% in a rural area adjacent to our hospital have a low BMI form of diabetes. So let me talk first about the history of this condition. I can't pronounce French words, but whoever Etienne Lassereau or whoever he was in the 1870s described two types of diabetes. Now, diabetes de gras is basically obese type 2 diabetes. But the other form was a lean form of diabetes, and they lasted for 10 years at a time when there was no insulin. Now, you can't manage type 1 diabetes for 10 years without insulin. They would invariably become acidotic and die. But they lasted, and they were in their 30s and 40s. So perhaps we were dealing with this condition way back, and there's a little review about that in a letter to the editor, which has been published a couple of years ago. So the first time this condition was actually recognized was in Jamaica in 1955, and it was called J-type diabetes. In the Lancet in 1955, a small series of patients who appeared malnourished and had a history of malnutrition and were also low BMI, and a good proportion required insulin. A lot of water passed under the bridge. By 1985, Dr. Jasprit Bajaj, who was the president of the International Diabetes Federation, labeled it as malnutrition-related diabetes, and being the president of the International Diabetes Federation, got it onto the classification of the WHO at that point of time. So this is the distribution of the cases at the time of Dr. Jasprit Bajaj, right across the tropical areas. Of course, they combined fibrocalculous pancreatic diabetes along with that, and they called it as a whole condition as malnutrition modulated diabetes. Criteria were drawn up. These two doctors from Orissa in India laid down the criteria for this condition. They said it was severe. Fasting glucose is more than 200, onset of diabetes before the age of 30, low BMIs, no ketoacidosis, the characteristic feature when you stop your insulin, a history of childhood malnutrition, insulin requirements up to 60 units per day, rural origin, and you rule out every other condition which is there in addition. There was a meeting in 1995 in India, in Orissa, a workshop on this, on the conditions which are peculiar to the tropics. But unfortunately, it appeared that the world, or rather the powers in the International Diabetes Federation, the ADA, and the European Society were not convinced and did not think there was adequate physiological basis for this condition, and took it off the WHO classification in 1998. Charlotte Boana from Rwanda wrote a review on this condition more recently and actually comprehensively covered the various countries which seem to have this disorder. And of course, then our physiological study was published in Diabetes Care, done at Vellore, which I will talk about in greater detail. So what is lean? We say lean by this Lancet classification, a BMI less than 19.2, and that should apply to you if you say South Asia. What do you mean by young? Less than 30 years. So that's me at the age of 19 years with a BMI less than 18.5. I'm not malnourished, but that's the definition of young according to this study. This is the Lancet publication giving cutoffs for different parts of the world. Once again, you might criticize this and say black population African, and Africa is a huge continent, whereas the West Africans are tall and big built, the East Africans are not. And so these cutoffs once again are rather arbitrary. So I'll come to a typical case over here. This is a gentleman from the rural area, about 20 kilometers from the hospital where I work at, came with young onset diabetes, diagnosed at 17 years, history of osmotic symptoms, responded to oral anti-diabetic agents, had weight loss, no ketoacidosis, no abdominal pain. He belonged to a low middle class family, and there was a history of low birth weight, duration of breastfeeding for about 2 years prior to that. This is his basic physical examination, essentially normal. The BMI is 15.9 with a waist circumference of 66 centimeters, and his other physical examination was essentially normal. His baseline tests, suboptimal control of glucose, lipid profile for you to see, normal renal functions, no ketosis, and we have done other workup. His GAD antibodies, zinc transporter antibodies, and IA2 antibodies were all negative, ruling out an autoimmune condition, and there was no evidence of malabsorption of fat. So this is an abbreviated result of the mixed meal challenge test. We draw an area under the curve with the C-peptides, but I'm just showing you the fasting and the postprandial C-peptides. And over here, basically, we are seeing that there is fasting beta cell dysfunction. In addition to that, you can see the postprandial C-peptide shows some sort of a response. There is no evidence of a fatty liver over here. This is the body composition of the patient, which is 17.4, and I think you've had a lot of talks on body composition in the last few days. This is low. If you have someone like me who doesn't have diabetes, my percentage body fat is around, say, 22, something of that sort. If you're a lady and you have diabetes, type 2 diabetes, your percentage body fat will be way above 35, sometimes more than 40. That's how it is. And this is really low over here. As part of a research protocol, and I'm not saying you need to do this, there was no family history, but a 62 gene panel was negative for beta cell dysfunction. And we also did a lipodystrophic panel, which was negative. And so this is the phenotype: lean, young, non-autoimmune, fasting insulinopenia, normal pancreatic structure, low total body fat, non-ketotic, no classical genetic disorder, low birth weight, low socioeconomic group, qualifies as type 5. This patient was lucky enough to respond to oral anti-diabetic agents. So let's go down to the pathophysiology and the pathobiology of this condition. I'm showing you this slide because if you look at this, these are all the risk factors for type 2 diabetes. Each of them is evidence-based. There is a reference for publication for each of them. But I'll focus on one of this, and I was quite enthralled to see that 2 days back when you had the oration, which I did not attend, that it was all about fetal origins of disease as well. But low birth weight and historical determinants. We know that this is a risk factor for type 2 diabetes, and these are a couple of articles which will tell you about the backgrounds of inequity and how they might in fact induce a greater prevalence of type 2 diabetes. So the Barker hypothesis, which was proposed way back in the late 1980s and 1991, showed that if you're born low birth weight, you have a thrifty phenotype, and you're more prone for developing obesity, diabetes, and hypertension 25 to 30 years later. And there are several wars and famines, like this one, the Second World War in Europe, where in Netherlands, women who were pregnant had calorie intake of only 400 calories per day, and subsequently had low birth weight babies and developed diabetes 25 to 30 years later. And that was type 2 diabetes, mind you, right? Just showing you that India and the region thereabouts has the highest prevalence of low birth weight and also has some of the highest prevalences of undernutrition in the world. By virtue of our 1.4 billion population in India, we also have that as an issue. I'm switching to a few studies which are done in Vellore, late 2009-2010, wherein we compared normal versus low birth weight individuals and did hyperinsulinic euglycemic clamps. 60 normal birth weight, 60 low birth weight. We did indirect calorimetry and NMR spectroscopy. And what we showed compared between the two groups, the low birth weight was shorter and lighter, had reduced muscle mass, increased diastolic blood pressure. The percentage body fat was high, but they did not have insulin resistance at the age of 18.5 or 19. They've also programmed, they had, despite their improved socioeconomic status, they took a low protein diet. And I want you to keep this in mind as well. The NMR spectroscopy showed virtually no fat in 20 to 30% of patients in the liver. No fat whatsoever. And very low fat contents, no trends towards fatty liver at that age. Just showing you that any form, this is the cluster classification of type 2 diabetes. As you know now that we have over here 4 clusters. All these clusters individually have a propensity. Low birth weight puts each of these categories, there's a history of low birth weight, there's an increased risk of low birth weight actually inducing diabetes in any of these clusters in type 2 diabetes. But that is putting the label type 2 diabetes right across any common garden variety diabetes that you call. Now let's talk a little bit about kwashiorkor and marasmus. I last saw my patient with kwashiorkor about 40 or more years ago, and I don't think there is very much of it in India. Marasmus, however, still exists, either a sporadic phenomena or in some parts, remote parts of certain low GDP parts of the country, it is still seen. Work from Jamaica about 10 years ago and published in the JCM by Dr. Michael Boyne from West Indies showed that the marasmic patients invariably had a history of preceding low birth weight. He also showed that they were insulin deficient and that they had hyperglycemia. When you did an oral glucose tolerance test in children with marasmus, they had insulin deficiency. Intriguingly, about 70 years ago, in the 1950s, a professor from India did research in Nigeria on kwashiorkor children and showed that, you can see these are weeks after nutritional rehabilitation. Low insulin levels at the baseline, and after nutritional rehabilitation, the insulin levels start rising, as you can see here, 2 weeks after and 3 weeks after. And so protein actually helps in improving insulin production. We all know that amino acids stimulate insulin production. But here you can see rejuvenation of beta cell function, as it appears to be, by giving protein or the rehabilitation that they actually had over here. Rat studies show, and due to epigenetic changes, transcription factor deficiencies, the pancreas, PDX1, gets impaired and insulin production is less. Similarly, and more intriguingly, once again, in the L cells of the intestine, it appears that there are transcription factors which impair incretin production. And I'll come to this when we talk about the biochemical and clinical work as far as this is concerned. 30 years ago, in the All India Institute of Medical Science, when primate studies could be done in India, now with ethics restrictions, it's not possible. But Ramesh Kadori showed that on exposure to low-protein diet for 6 weeks, there was reduced insulin secretion and reduced hepatic glucose disposal in rats. Dissected islets from rats and mice have shown that the islets are much smaller when they're exposed to malnutrition. Coming a bit to the epidemiology, this is East Pakistan, because before it became Bangladesh in 1961, this was a study which showed that a large proportion, almost 40% of patients were underweight and had hyperglycemia. The ones who were underweight, or the proportion of those who had diabetes, were grossly underweight, malnutrition, BMI is less than 18.5. The age that you can see over here also ranges into the older age groups, 30, 40, and 50. Of course, we don't have insulin measurements in this group, but once again telling you how common it was at that point of time when socioeconomic status was much worse. So more recently, publications from Uganda, Jamaica, and Ethiopia have shown that this condition exists. And this study from Uganda shows that those who have a low BMI have C-peptide insufficiency, beta cell dysfunction, and also have a very low percentage body fat. This is not by DEXA, this is by bioimpedance. So low beta cell function with low total body percentage fat as well. CLAMP studies from India, hyperinsulinic, this is way back almost, once again, 30 years ago, have shown that this condition is not insulin resistant. They are highly insulin sensitive. Once again, from Thailand, Mandi Bajaj was the former president of the American Diabetes Society. He did work in Thailand and showed, once again, no evidence of insulin resistance in lean patients with diabetes as well. And a review article by Nikhil Tandon and Ashok Balasubramaniam highlighting this particular condition. So I'm coming to the physiological study which was published in 2022 in the diabetes care. And this was a comprehensive study wherein we took classical cases of what we call today type 5 diabetes, at that time called malnutrition modulated diabetes, did imaging, did hyperinsulinic euglycemic clamps, indirect calorimetry, and genetics in all these subjects. And this is my collaborator, Professor Meredith Hawkins, in New York, but the studies were all done in CMC Vellore. So this is a study group of 20 low BMI cases, 20 type 1s, classical type 2s, lean controls with BMIs less than 19, and overweight controls with BMIs more than 30. This is the CLAMP study. It's called a total pancreatic clamp. We control all the glucose values. We did this also in type 1s and type 2s, mind you, besides the malnutrition modulated diabetes. Clamp the glucose is 90 milligrams per deciliter. We also give them hormones, growth hormone, glucagon, and somatostatin, and they go through a recovery phase subsequently. Now, what we found was, with the mixed meal challenge tests, you can see over here that they have insulin deficiency. C-peptide levels are low, not as low as type 1 diabetes, the pink line over here, but low. And of course, this is type 2. The area under the curve is significant, hyperglycemia, but not as bad as type 1 diabetes, but worse than type 2 diabetes. The hepatic glucose output using deuterated glucose over here is very low. Hepatic glucose output is low, not like type 2 diabetes, which is high, right? Which is known as type 2 diabetes. The peripheral insulin sensitivity, we call it the M value, was more than 10, which means very good insulin sensitivity. And the hepatic glucose output comparatively for type 2 the peripheral insulin sensitivity for type 2 diabetes is very low. So this condition is quite different from type 2 diabetes. Beta cell deficiency, peripheral insulin sensitivity is good, hepatic glucose output is low, and low percentage total body fat. 35 to 40% of these patients respond to oral antidiabetic agents despite the beta cell insufficiency over there. Now, the incretin study, and this is done by my colleague Felix along with our postgraduate Venkat, profound GLP-1 deficiency seen both on the IGTT and the OGTT over here. And this is probably due to the malnutrition affecting the L cells of the intestine. The enteroendocrine cells have not yet regenerated. So now let's construct things. After a publication in Diabetes Care in 2022, this group reviewed the publication in Scientific American and talked about it and highlighted the importance of this condition. And of course, in April 15th, it was relabeled as type 5 diabetes. We had a consensus meeting in Vellore where 40 clinicians, scientists and basic scientists all met together, including people from Sri Lanka, and classified this condition. A more recent publication on the physiology of this condition talks about the discussions, the debates, and the controversies of the condition as well, but non-autoimmune, low BMI, low insulin secretion, low hepatic glucose output, low percentage body fat, incretin deficiency, low birth weight, and postnatal undernutrition. This is a review in the IJEM talking about it, and this is the upcoming publication which is going to come out in the Lancet Global Health by the middle of September. It covers the criteria roughly in terms of what we should be looking for and also the occasionally reported features in type 5 diabetes. So this is a cartoon drawn by Yajnik, and I'm talking about low birth weight again. If you have undernutrition in utero and overnutrition post-delivery, you develop type 2 diabetes, thrifty phenotype. But if you have undernutrition in utero and subsequently you have undernutrition post-delivery, it's a double hit, and therefore you develop type 5 diabetes. Insulin resistance on the top, insulin deficiency at the bottom as well, besides the other physiological characteristic I told you. Now the questions here are, is this a variant of type 2 diabetes? We have the cluster diagnosis of diabetes, classification of diabetes now, which divides diabetes into 4 types, right? The severe insulin deficient diabetes is what is called. I don't like the word severe because it's not necessarily invariably all that severe. It's not as though all of them have very low C-peptide levels. Some of them actually have normal or borderline C-peptide levels. So I'm just going to compare with some existing studies. This has been done in Chennai by Dr. Mohan and his group. This SIDD group over here had a median BMI of 24.9, which is totally different from our type 5 diabetes who have BMIs less than 18.5, right? Another study more recently published showing this very large population, a huge from many clinics in urban areas across India, lean BMI diabetes less than 1.5%, but they are younger, male preponderant, and they have low C-peptide levels and low lipid levels. Do you still want to call this type 2 diabetes, or do you like to call it something else? More recently, from the tea gardens in Assam in India, laborers have been studied using a very simple measurement, the HOMA beta, showing that these individuals who were underweight and malnourished had low beta cell function, both the males and more profound in the females. So it's out there. There is a condition which has to be recognized, has to be treated, and probably researched better. I'll come very briefly into the differential diagnosis, but this is the algorithm that we use over here. And with the permission of the chairs, I would need another extra 2 minutes, if you don't mind, to talk. Thank you. So, differential diagnosis, anything which can cause lean diabetes should be considered. Slowly evolving immune-mediated diabetes, right? Fibrocalcious pancreatic diabetes. And these are the two top conditions which should be ruled out before you think about type 5 diabetes. You have to rule these out, which means you need to check C-peptides, you need to do a scan of the abdomen. Ultrasound is okay, but a CT scan would be certainly far better and less observer-dependent. Monogenic beta cell dysfunction, but which ones? Which ones should you look at? Mainly MODY 5, not type 5. They are lean. Most of the other MODYs actually have a BMI which is higher, more than 23, sometimes more than 25. Cystic fibrosis, pancreatic disorders which also occur in our population. We see it in India now, and I'm sure it's there in Sri Lanka, should be also ruled out. And a whole host of other genetic disorders which should be considered in this situation. Lipodystrophy, but this is a condition with insulin resistance. Low percentage body fat, yes, but high triglycerides, which is there, and the C-peptides are elevated, so they have insulin resistance and not deficiency. And this is our publication on lipodystrophy. They have high C-peptides, hypertriglyceridemia, and they have fatty liver, which does not occur in type 5 diabetes. Wolfram's-like syndrome, rare condition, autosomal recessive, but the reason why we should think about it is because in the initial phase, in the milder types, diabetes comes first, optic atrophy and deafness comes much later, and they are not ketotic. So it can be mistaken. And finally, HIV lipodystrophy, but of course this is obvious. They have only mild diabetes, the C-peptide levels are not high, and they on antiretroviral therapy, which actually induces the lipodystrophy in these conditions. And they have partial lipodystrophy, but they have mild diabetes and are easy to treat. And finally, type 5 diabetes. So in a resource-poor setting, this is what you need to do. Take a very good history, draw a good pedigree chart, measure C-peptides, GAD antibodies, and a CT scan. Now, if you have resources, then you need to do the other things like genetic testing, etc. But body composition can also be done with a bioimpedance device, which is much cheaper than a DEXA. So I'm just summarizing the findings. A metabolic disorder which is insulin deficient, preserved insulin sensitivity, low total body fat, and reduced hepatic glucose output. Quite different from type 2 diabetes. Antenatal and postnatal insult. To what degree? We need to do more research. Treatment, what do we need to do? Oral antidiabetics seem to work in about 40%, but once again, specifically which ones, we need further research. Thanking our funding agencies and all my colleagues who have helped out with the research. Thank you so much for your patient listening. Thank you.
Thank you, Nihal, for that very great, elegant lecture on type 5 diabetes. And we are proud that you are here, one of the greatest scientists in the subcontinent in diabetes.